Please start, sir.
Okay. Thank you. Thank you for our technical team. And on behalf of Bayer Oncology, we just want to go for the warm welcome with the very most senior consultant medical oncologist from Sparsh Hospital, Bhubaneswar. Dr. Ghanasham sir who is with us. And we are going to welcome sir for in this session. Today's first session and this session we are going to introduce with our topic today's topic with obviously it's with dendrotamide, and the topic is breaking barriers in MHSPC doublet with dendrotamide with aranot. So I want to sir welcome sir in this session.
Thank you so much. And so, are you able to see my slides?
Yes sir, you both of you and your slide are visible sir.
Because I have a very bad pharyngitis. So,
No issue, it's very much visible sir.
so very good evening and thank you, Bayer, for this opportunity.
Welcome sir.
So, my topic will be breaking barriers in metastatic hormone sensitive prostate cancer using a doublet. And we'll be talking about the drug danilotamide plus the backbone ADT leads the way with the Aronet study. So this is a disclosure. So now the standard of care in metastatic hormone-sensitive prostate cancer has evolved to combine ADT with AR inhibitors like abiraterone or docetaxel. So this has been for almost more than a decade now. So if you see this, the cartoon, so 2014 charted showed us docetaxel plus ADT and subsequently docetaxel plus ADT again in the stampede in the arm C. So followed by abiraterone and ADT in the latitude trial, and in 2018 the same stampede had the arm G where abiraterone plus ADT. So thus docetaxel followed by abiraterone got established in a metastatic hormone sensitive prostate cancer. Subsequently, people tried using enzalutamide in this setting. That was the Arches trial, followed by another trial including enzalutamide was also there, Enzamet. But the difference between Arches and Enzamet was that Enzamet also allowed docetaxel to be given, but it was not compulsory. But few of these patients received Enzamet. So by that time we had the third drug, that was apalutamide, again in the similar setting, that was Titan, again another positive trial. So ADT plus apalutamide. Then we entered into an era of a triplet, which was the piece one, and we know that we have the 6-year survival follow-up, so which included putting all the guns together, so ADT, abiraterone, and docetaxel plus minus local site radiation. In the same space, so Arasens also subsequently was a positive trial where they include ADT plus dalatomide and docetaxel. In 2024, so after the 3 drugs got approval in a doublet setting, so there was an Aronet trial and the Arasec. So Arasec was a phase 2 trial, whereas Aronet, which my center was also a part of that. So dalatomide and ADT was in a phase 3 trial. So despite treatment with ARPI plus ADT or docetaxel plus ADT, a large proportion of patients metastatic hormone sensitive prostate cancer will progress to probably a metastatic HRPC, which is a bad disease, and this is going to happen in next 3 years or so. So if you look at the natural history of a prostate cancer, so on a diagnosis, you will have an M0 disease, so known as non-metastatic HSPC, which is a local disease. So from this, patient can progress into a metastatic hormone-sensitive prostate cancer, or this can progress into a non-metastatic HRPC. So till few years back, these biochemical relapse were not into focus. Subsequently, abiraterone and then darolutamide came and showed that non-metastatic HRPC is totally a different biology. So if you ignore these patients, then probably you are compromising on survival for certain this group of patients. So first approval for darolutamide came into a non-metastatic HRPC, where it is a rising PSA despite castration testosterone levels. And the worst disease in the whole cohort in a prostate cancer journey is a metastatic HRPCA. So probably we have not much to do at this moment. So we can find out some biomarkers and probably so that is going to lengthen the survival of these patients. So this cartoon will make us understand. So what are the drugs available for prostate cancer in different situations? So these are androgen synthesis pathway throughout body with drugs targeting androgen synthesis. So the mentor of this whole course is a pituitary. So we talk about pituitary adrenal axis and we talk about pituitary testicular axis. So both these actives are active while you're treating a prostate cancers. So when you are when you are using a medical castrations with GnRH analogs, with leuprolide, with gossaline and triptolin, and there are GnRH antagonists like degarelix and the relugolix. In terms of androgen receptor antagonists, so we have come a long way from bioclutamide, flutamide, nilotamide to enzalutamide, apalutamide, darolutamide, and there are now certain SERDs like what we have seen in breast cancers. The other group of drug is these are enzyme inhibitors, CYP17A1 inhibitors. So we have used in the past during early days about DM when these drugs were not available. So ketoconazole, and then subsequently for almost now 2 decades or so, we have been using abiraterone. So once you see a patient of metastatic hormone sensitive prostate cancer, so after you've done imaging, so in earlier days we used to do CT scan, then subsequently PSMA PET scan has been normal. So ADT remains a backbone, but hardly today in 2026 you will have a patient who is going to receive ADT alone. But there are patients, somebody who is in 80 plus with a frailty, with lots of comorbidity, so probably very difficult to add on a doublet or triplet. So you still gives us some survival with some quality of life with ADT alone. But this is a rare situation, so it is not practiced much. So that's why ADT alone has no much role, though it is already in the guidelines, but probably that may not be the right way. So what is commonly done is a doublet, and so you have now more options. So starting from those charted and stampede days, to docetaxel, then subsequently abiraterone, then enzalutamide, that is from Enzamed, and then from Titan apalutamide. So what's new that we have? So docetaxel rarely today ADT plus docetaxel is used, and now so the new kid on the block is a darolutamide. So otherwise, so one docetaxel and 4 other hormonal agents like abiraterone, enzalutamide, and apalutamide and darolutamide. So these are 5 in a setting of a doublet. So ADT plus doublet. So what are options for triplet? As I said in Enzamed study, so docetaxel was allowed, but the charm of triplet came into was the PEACE-1 study, that was docetaxel abiraterone, and subsequently in the Aracen study was docetaxel plus darolutamide. But if you see the docetaxel plus enzalutamide Enzamed study, so it was not powered to use this regimen as a triplet. So probably, so that is not a recommendations in terms of a triplet. So we are going to use enzalutamide along with ADT as a doublet, but triplet trial was not powered, though enzyme allowed patients to receive docetaxel. So for triplet, we have docetaxel plus abiraterone and docetaxel plus darolutamide. So this whole has been put into one slide. So ADT plus docetaxel came from Charted and a Stampede in the group C. Abiraterone came from Latitude and Stampede, that is group G. Titan came from apalutamide, and enzalutamide came from Arches and Enjamate. Enjamate was where even few patients received docetaxel. And darolutamide came from Arasec and Aronate. The difference was Arasec was a phase 2 and Aronate was a phase 3. For a triplet, if a young fit patient is there, if you want to give the best survival, so you want to add abiraterone. If the patient is a non-diabetic, sugars are well controlled. If you are worried about the steroid part, then probably you can use Arasens, which is another triplet darolutamide. So in a docetaxel plus ARPI, so you have two regimens, with one is abiraterone and darolutamide. So where the maximum survival has been seen in a metastatic hormone-sensitive prostate cancer. Now look back 2023 NCCN. So if you look back 2023 NCCN, the systemic therapy for castration-sensitive prostate cancer. So M0 monitoring or ADT. So for M1 disease, so metastatic hormone-sensitive prostate cancer, so 2023 never talked about high volume, low volume. They never talked about synchronous or metachronous, or even the BRCA2, the whole story. So this has a preferred regimens where ADT with, so doublet were the preferred. So ADT plus abiraterone, ADT plus apalutamide, or ADT plus enzalutamide. So because by this time the trials of darolutamide was on, subsequently ADT with docetaxel as one of the following. By this time the PIS1 data were available and the Arasens data were available. So these were in abiraterone and darolutamide, for these were for the fit patients. ADT with an EBRT, which we today call about oligometastatic disease. So EBRT was there for low metastatic burden. And as I said, ADT alone for a very frail patients, elderly frail patient with multiple comorbidities. So twisting the tail for metastatic hormone sensitive came when we jumped from 2023 to 2026. Then understood that so all diseases in the metastatic hormone sensitive prostate are not the same. So now you have to look at synchronous versus metachronous. You have to look at high volume, low volume according to the charted. Oligo versus a florid systemic disease. So 15% of the patients will be a BRCA2 versus non-BRCA. And whether you are going to use singlet, if at all, doublet, and there are certain patients who will be benefiting or able to tolerate triplet. So moving from 23 to 26, now you see the 26, the top one. So they mentions high volume metastatic CSPC, which was not there in the 2023. And if you are looking at a high volume metastatic CSPC, so synchronous or metachronous doesn't matter much. So here ADT with docetaxel has been preferred as compared to in 2023, it were doublet. So synchronous or metachronous high volume metastatic HSPC. So triplet of PIS1 or Arasens are the choices. Other recommended category to be can be apalutamide and enzalutamide. The second category can be a doublet for those patients probably who may not be able to tolerate docetaxel. So you can choose the combination of ADT plus abiraterone, apalutamide, enzalutamide, or even darolutamide. And the third is if there is a driver mutations or there is a biomarker available, as I said, in 15% of patients with a BRCA family. So ADT with useful in certain circumstances like a BRCA2 mutant, so niraparib or abiraterone. The second group will be a low volume. So we talked about high volume. In low volume, so you'll have again two groups. So low volume synchronous or low volume synchronous with oligometastatic disease. The other group will be a metachronous low volume disease. So in a synchronous low volume or synchronous oligometastatic, so we'll prefer, since these are low volume, so we'll prefer a doublet. Certain patients, younger patients, can still consider, we'll see in the ARONET study also. So ADT with docetaxel, the triplet can be offered. Again, oligometastatic disease, so EBRT helps and improves survival. And as I said, certain patients with BRCA mutant, though category 2B, you can use niraparib or abiraterone. If this is a metachronous low volume disease, then metachronous low volume, so you'll prefer a doublet. And for a BRCA2 mutant, you can use niraparib and abiraterone. So factors to consider before selecting ARPI. So you look at a drug, that is safety and tolerability. You look at a drug that delays castration, that improves prolonged PFS or overall survival, and has that drug included health-related quality of life or not. So since this is a disease of an elderly, so there are many things that will come into picture. And while you plan for a therapy, is the patient elderly? Is the patient frail? How is the performance status? Are they fit for chemotherapy? Are there any HRR, like as I said, BRCA? Because these patients will have a risk of fall. There will be a polypharmacy. And so one of the rare patients, probably you can modify and give chemotherapy like 2 weekly docetaxel of 50 milligram per meter square, because today there are different docetaxels, so where tolerability is not a major issues. And are you looking at a high volume of disease, and these patients are requiring early response and control of hematuria, if at all? And then, so together, how much toxicity is this patient? How is the support system? Who is taking care of the patient? So these have to be included when treating an elderly patients with a minimal support at home and elderly and frail. So now moving into darolutamide as a drug. So the pivotal trials, so there are at least 4. There are many others. The 4 is Aramis. That was the first thing. That is how darolutamide came into the prostate cancer space. It's a phase 3 trial, non-metastatic HRPC. So today we understand that non-metastatic HRPC. So darolutamide and abiraterone are the choices, including apalutamide also. So this has improved. So once you are treating these patients, so it is going to delay these patients to move into a metastatic HRPC, which was not there before the approval of this drug. Second is Aracens, again a phase 3 in a metastatic hormone-sensitive prostate cancer, where triplet was used. Aracec, as I said, this is the only phase 2 trial in a metastatic HSPC, where doublet. ARONET, the similar group of patient, but it was a phase 3, and again doublet of ADT plus darolutamide has been used. So we'll be discussing ARONET now. So unmet need was there in this space, metastatic hormone-sensitive prostate cancer, because we know that you need a safer drug and which does not add more toxicity, and there should be a low drug-to-drug interaction. By this time, the Aracen study was published. That was a triplet, and that showed benefit. And India got its approval in 2023. So that is what the background for this subsequent ARONET study to have, which was a global phase 3, and that was as a doublet. So darolutamide plus ADT with docetaxel is a standard care for metastatic hormone-sensitive prostate cancers, and we have seen that improved the survival. ARONET was designed to provide a new treatment option without docetaxel. So this was presented in ASCO and published in JCO in 2024. So our center was also a part of this, and luckily, probably after many years, Asian and also India has a substantial patient number in this study. So this was a randomized double-blind placebo-controlled phase 3 study. So more than 600 patients, histologically and cytologically confirmed. So performance status of 0 to 2. So many of the trials you won't see of a PS2, but this included PS2 patients. The stratification factors were visceral metastasis, yes, no, and prior local therapy in the form of radiation mainly, yes or no. So the randomization was 2:1, 2 in favor of the experimental arm, and the dose of darolutamide was 600 milligram BDs, that is 1200 milligram daily dose. And in this trial, the ADT was Zoladex 10.8, that is Gossaline was used. The primary endpoint was radiographic PFS, and there were multiple secondary endpoints, including rates of undetectable PSA, which is defined as PSA of less than 0.2 nanogram per ml. So another important thing was taken into consideration was time to pain progression. And other pre-specified endpoints, what we see is the PFS2 and time to SSC, and also health-related quality were included. The good part of this trial was that there was a crossover allowed, and for those patients, selected endpoints, OS and safety were there. Median follow-up in the darolutamide group was 25.3 months versus 25 months in the placebo group. So Asians represented almost 30%. And if you see PS1 to 2, the symptomatic patients are almost 50%. And if you see the median PFS, which was 21.4 and ranges up to almost 16,000. If you look at a metastatic, de novo was 70% and rest were recurrent disease, previously treated with the neoadjuvant or an adjuvant. So in terms of volume, again, 70% were high volume, 30% were low volume. And the country representations of various prostate cancer trial, if you look at Aronet, 30% were Asians, and India contributed almost 61 patients in the darolutamide arm, and in the placebo arm, 32 patients. So we had 6 patients from my center, and three were in the placebo and 3 were in the darolutamide arm. So coming to the primary endpoint, which was radiographic PFS. So if you see the graph, so the hazard ratio for radiographic PFS was 0.54, significant p-value. So the median PFS was not reached in the darolutamide arm, where in the placebo arm it was 25 months. And you can see there is a almost 46% decrease in the death. So if you now come to the forest plot, so for the benefit across subgroups, so the high and low volume disease. So if you see, so at the high volume disease has a hazards of 0.60, low volume has a hazards of 0.30. So definitely low volume has a substantial benefit, but the high volume too benefited. Second important is that looking at the visceral disease, yes, no. So those who did not have visceral disease, only a bone disease, has a hazards of 0.52 as compared to visceral metastasis. They had almost hazards of 0.71. Again, the quantum of benefit was in the no visceral metastasis. Third was a prior local therapy, those who have received local therapy, and we know that many of these oligometastatic disease in solid tumor. So if you include local therapy, so that is going to improve your survival. So those who receive local therapy has a hazards of 0.34 versus who did not has a hazards of 0.59. So probably the best patients were probably a low volume disease, no visceral metastasis, and prior local therapies. So coming to the secondary endpoints in terms of ways, in terms of time to metastatic CRPC, time to PSA progression, and time to initiate of subsequent systemic therapy, post progression, and time to pain progression. So was significantly in favors of the darolutamide arm. So by the time of presentation in 2024, the waste data was not mature. So patients are on a follow-up till date. So if you see the time to metastatic CRPC, which was not reached in the darolutamide arm, but for the placebo arm, it is 13.8 months. If you see the hazards of 0.40. Time to pain progression, again favoring the darolutamide, but it is not reached. In the placebo, it was 29.9 months. So delay in time to pain progression can be of high importance to patient because these patients continues to come to you with pain off and on and have not been demonstrated with other AR inhibitors prior to this. So undetectable PSA, which is defined as PSA of less than 2 nanogram per ml at any time during the treatment, so was more in the darolutamide arm, 62.6 versus, so almost 3 times more in the darolutamide arm as compared to placebo. So time to PSA progression was also not reached in the darolutamide arm versus 16.8 months in the placebo arm. So 63% of patients in the darolutamide arm doublet arm attained a PSA of 0.2 nanogram per ml. These represented a 69% improvement in time to PSA progression in the experimental arm. So now, if you see a higher proportion of patients, be it high volume or low volume, has actually had achieved a undetectable PSA. So if you look at a high volume, again, you see a big peaks favoring a darolutamide in high volume. Similar is the story for a low volume, where the peaks are much more in terms of undetectable PSA in this patient group. So what about the second subsequent therapy on progression? So almost 32% patients in the darolutamide, 10% more patient had to go early for a second line treatment. And these were various second line treatment, but because this was a doublet versus only ADT. So that's why docetaxel was probably the commonest treatment that was available for both these groups on progression. Now coming to toxicity of this drug, so grade 3 and 4 or grade 5, no much difference as compared to the experimental versus the placebo arm. So that means darolutamide did not add much of toxicities. But if you see a treatment emergent adverse event leading to permanent discontinuation of darolutamide or placebo, it was much less in the darolutamide arm, that is 6% versus 9%. The safety profile of darolutamide in ARONET was independent of a PSA response and consistent with the favorable tolerability first seen in the ARAMIS and the ARASENS. The most common other adverse events that were seen in both the groups, so starting from anemia, arthralgia, and most of these prostate cancer patients will have UTI and the back pain. So drug-related, we see occasional elevation of liver enzymes like AST, and since these patients will receive ADT, so hot flushes can be seen in many of these prostate cancer patients, like what we see in a postmenopausal ladies. So probably fatigue was one of the most common toxicity as compared to the placebo arms, which was an outstanding here. So many of these drugs, novel drugs, what we've seen across all cancers, cause fatigue, and we don't know much about the reason of this, and many a times psychological counseling probably helps. So no obvious drug are available for this unless and until you rule out anemia, you rule out hypocalcemia, hypovitamin D, or even hypothyroid. So these are again certain toxicities like hypertension and worsening of diabetes and hyperglycemia, certain cardiac arrhythmias. So these were seen across both the groups. So nothing significant or contributory. So that one comes as a positive, positive in terms of quality of life today for any metastatic solid tumors. So quality of life issues are important. If you see a time to deterioration of a fact-free total score, so this was almost 16.6 months in the experimental arm versus 11.5 months. So that is almost 5.1 months benefit. So darolutamide probably is the first and only AR inhibitor demonstrate clinically meaningful delays in pain progression and overall well-being. So if you look at the social and the family well-being, if you look at the functional well-being and the urinary symptoms, so all these actually favor darolutamide as compared to a placebo. So this is an important when you treat this elderly gentleman. So to conclude, darolutamide plus ADT after docetaxel, then abiraterone, then enzalutamide and aprotamide. So this is a new combination in your kitty for your patients or metastatic hormone-sensitive prostate cancer who are not a candidate for a triplet. It is improved radiographic PFS, which was the primary endpoint. So we are yet to have the OS. So darolutamide showed a benefit across all secondary endpoints. There were almost 10 secondary endpoints. So darolutamide was associated with deep PSA response, which was taken as less than 0.2 milligram per deciliter, regardless of the baseline PSA. And we have seen, so there were patients, so the highest has been 16,000, though the median PSA was 21. So darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, which is of utmost important in a prostate cancer because this cancer is usually associated with the bone metastasis across all the bones, appendicular and axial bones. So in terms of quality of life, overall well-being, including social and family well-being, functional well-being, and urine symptoms, and darolutamide had a favorable safety profile, except probably which was a starking difference between the placebo was a fatigue, and darolutamide plus ADT without docetaxel today is an additional standard of care for metastatic hormone-sensitive prostate cancers after initial 4 approvals. So that was the last slide. So thank you for listening. So any questions, I'll be happy to answer.
Thank you, sir. Thank you for your nice presentations. And
Thank you,
there
sir.
are any
Few of my students have joined, but okay.
Yes, sir. Sir, thank you for this wonderful presentation. Hope in future we'll get your guidance regarding our product, and in the future meetings we will definitely include you in some different manner. Maybe in your sir moderation part is it is well known to all, so we will include you as a moderator in our coming meetings. So, sir, for the timing, it's over for this meeting. So, sir, once again, thank you and good night from Team Dua.
Thank you. Thank you so much. Take care.
Thank
Bye.
you, sir. Thank you. Bye. Good day. Yeah, take things. We can conclude.